Good morning, everyone. My name is Joan Batorf, and I am joining you from UBC's Okanagan campus today. And before we begin, I would like to respectfully acknowledge that our campus is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And I'd also like to acknowledge that you may be joining us from many places today, both near and far. And I want to acknowledge the traditional owners and caretakers of those lands as well. So I'm especially delighted to introduce this session today because it's really, we're celebrating 100th anniversary of the discovery of insulin. And what makes it especially special, it was a great Canadian discovery by Frederick Banting, as many of you may know. And it brought a miracle to many people. But research hasn't stopped over the last 100 years. It's continued to progress, and we're going to hear about some of that today, and better yet, what benefits that research has brought and a look into the future. And so hence the title of our session, Hope on the Horizon for Diabetes. I am pleased to have 4 panelists with me this morning. And each are going to do a short presentation, and then we will have time for questions and comments at the end. Our session is an hour and a half today, so we're happy to leave ample time for questions and comments. So I encourage you to jot those down as we proceed through the presentations, and we will have the chat function operating for you to record those questions and comments at any time, but we won't address them until the end. And we'll have at least half an hour at the end to address those comments and have a conversation with everyone. So look forward to that discussion. You will notice that there is some closed captioning on your screen, and you can turn it off. If you find it distracting, you can select the live transcript button at the bottom on the menu bar and adjust it as you wish. Today's event is brought to you both by the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan, but also the BC Diabetes Research Network, situated most prominently at UBC, crossing both campuses. So without further ado, I'd like to introduce our first speaker, Bruce Verchere, now I've forgotten it, Verchere, who is professor at the Department of Surgery and Pathology and Laboratory Medicine at UBC Vancouver campus. And he's also with the Childhood Diabetes Lab at BC Children's Hospital and director of the Center for Molecular Medicine and Therapeutics at the Irving K. Barber as the Irving K. Barber Chair in Diabetes Research. So I'll turn it over to you, Bruce. Thank you.
Thank you very much, Joan, and thank you all for joining us this morning. I trust you'll tell me if my screen is not correct. I'm really delighted to be joining you on this 100th anniversary of the discovery of insulin as we celebrate diabetes research. And I too would like to recognize that here in Vancouver and where I work at UBC in the Point Grey campus and the Lower Mainland of BC Children's Hospital is on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. I think this recognition is particularly pertinent when we talk about diabetes, a disease which has really disproportionately impacted Indigenous peoples, especially with the impact of colonialism. So I want to talk about new frontiers in type 1 diabetes research and therapy, and particularly with a focus on a particular cell, the target of the immune system in type 1 diabetes and an important player in type 2 diabetes, and that is the pancreatic beta cell, a cell that we study here in my lab at BC Children's Hospital. Let me start with a really brief introduction of diabetes, and because I'm at Children's Hospital, I'll focus on childhood diabetes. There's about 3,000 kids in the province that live with this disease. It's important to know that it's a lifelong and life-changing and currently incurable disease. And these kids, like my friend who is close to one of our speakers today, Fiona, a little older now, but she's endured many years of finger pricks and insulin injections to stave off the complications of diabetes. And we need to keep in mind that diabetes comes in multiple forms, and you're going to hear about type 2 diabetes a little later in this session, but I'm going to focus on type 1 diabetes. So this is a disease in which there's an immune attack, an autoimmune attack on the pancreas, particularly the insulin-producing beta cells. These kids need insulin to survive, and there's about 2,500 children living in the province of BC right now with type 1 diabetes. It's important to point out that it's not all kids who get it. You can get type 1 diabetes as an adult. Type 2 diabetes is the more common form, and I won't talk much about that because you're going to hear more about it, but it is associated with obesity and aging. There are children in BC with this form of the disease. And in that form, insulin doesn't work as well, and the pancreas doesn't make as much as it needs to. And there are other forms. There's diabetes of pregnancy, gestational diabetes, as well as rare single gene forms that we won't be talking about today. So diabetes comes in many forms, but the major forms are type 1 and type 2 that we'll be talking about today. And I'm going to talk about type 1 diabetes, the form of the disease that was really transformed by the remarkable discovery of Fred Banting, Charles Best in 1921 that Joan mentioned. And there, just to say that a child is diagnosed with diabetes in BC every few days, and there's currently about 300,000 Canadians living with type 1 diabetes. So where does insulin come from? A little bit of anatomy for you all and a bit of history too, I suppose. You may have heard the term islets of Langerhans. They're so-called islets. These are clusters of cells named after their discoverer, Paul Langerhans, who was a German medical student who was looking under the microscope, and he noticed within the sea of the pancreas, these small clusters of cells that he called islets, because if you look at Google Maps or Google Earth, it really does look like an islet. And so these are clusters of insulin producing cells and other endocrine cells that reside in the pancreas. We all have about 1 million of them in our pancreas. And in people with type 1 diabetes, these are the target, as I'll show you, of autoimmune attack. And if we zero in a little bit further at the electron microscopic level, this is what a beta cell looks like. And you can see these really beautiful little fried egg looking things inside the beta cell. And they are actually insulin granules. So those are little granules that are chock full of insulin in a crystalline form that's waiting to be stimulated to be released, for example, after you have a meal or glucose is ingested. And this is a closely controlled process. Insulin is stored until it needs to be secreted to keep blood glucose under control. And in type 1 diabetes, and this is first I'm going to show you in a mouse model and then in humans, we know that type 1 diabetes is an autoimmune disease, in part because we can visualize the attack on the pancreas. Here you can see an islet, this circle here, and these dark staining cells here that seem to be growing in number and attacking the islet are doing exactly that. They're recognizing proteins in the insulin-producing beta cell actually expressed on the surface and attacking and killing the beta cells. And it's that loss of beta cells and dysfunction as well that causes diabetes. And we know this is also true in humans from more recent studies where we've been able to obtain pancreas from humans who had type 1 diabetes at the time of death and donated their organs for research. And here the beta cells are stained green, so insulin is stained in green, and the immune cells are stained in red. You can see in this person with type 1 diabetes, there's loss of beta cells, and there's a lot of these immune cells attacking those cells, the beta cells. I would also point out that in someone with type 1 diabetes, there still are beta cells around. So it's not a total loss. And you may see that in the textbooks if you've studied diabetes or read about it. And this is really important. So we now know that there's both beta cell death and beta cell dysfunction. And why is this important? It gives us potentially a target to regenerate beta cells or rescue or preserve those ones that are still there if we can stop the immune attack. So here we are 100 years after this remarkable discovery by Fred Banting and Charles Best, and I would add Collop and McLeod to that, because it was really a team of 4 that made the discovery, although we often just hear the term or the alliterative pair of Banting and Best. And in 1921, they made this really remarkable discovery that saved the lives of many living with diabetes at the time. And here's just one example. It's a picture of a little child named Teddy Ryder, and I'm going to read what it says because it's a bit small in print here, but it says the first photograph shows 6-year-old Teddy Ryder. When he first arrived in Toronto, he weighed 27 pounds. This was an American boy who was essentially dying of type 1 diabetes, came to Toronto to get the miracle treatment. And the second photograph shows him a year later, a healthy looking 7-year-old weighing 45 pounds. So what a remarkable life-changing treatment. And Teddy Ryder lived well into his 70s. I think he died in the 1980s, was one of the longest people in terms of living on insulin. But he took it every day. He still faced some complications of the disease. But to give you an idea of the impact that diabetes research had, that this research had at the time, Canadian medical research, he wrote a letter to Fred Banting. It says, Dr. Banting, I wish you could come to see me. I'm a fat boy now and I feel fine. I can climb a tree. But insulin's not a cure. And even Fred Banting said that. So my friend Fiona here has had many injections and checks her blood sugar many times per day still. And Fred Banting says it's not a cure. It is a treatment. So it allows people with diabetes, with type 1 diabetes, to live a long and pretty healthy and happy life, but it's still life-changing. They have to continually check their blood sugars. They have to continually administer insulin, either by injection or pump, and they still have risk of low blood sugars and high blood sugars that can cause the complications of the disease. So I'm going to talk about new research and particularly try to touch on research that's going on here at UBC, in the UBC system, because I think there truly is, in keeping with the theme of this session, real hope on the horizon for new therapies for type 1 diabetes, with the goal of an insulin-free world, the idea that people living with type 1 diabetes will no longer require insulin to live a normal life. And I'm going to focus on 4 areas, some in a lot more detail than others, just because that's where some of the local research is and perhaps some of more interest to people in this session, but I'll be happy to answer questions on any of these. I'll talk about islet transplants, or replacement of the insulin producing beta cells by transplantation, the artificial pancreas technology, which is really exciting, immunotherapies, and a little less on beta cell regeneration therapies. And I'll end with some of our own research on biomarkers in clinical trials, which can help with prediction of disease. So transplantation and artificial pancreas share a similar role or idea, and that is that, can we replace that lost beta cell function in diabetes? Can we bring back insulin production and secretion in a precisely regulated way to control the blood sugar by replacing those cells that are lost? And we can do that by transplantation of the cells, and that's done by transplantation of islets or stem cells, which I'll show you in a moment, or really interesting, the artificial pancreas. And this is not a particularly new idea. Look at this, 60 some years ago, one of the first prototypes of an artificial pancreas, certainly not something that someone could go swimming with or play sports with. But the idea has been around a long time that you could have a machine that could measure your blood sugar and release the right amount of insulin. Now we have insulin pumps, which safely give the correct bolus of insulin, and the patient can administer that. And more now we're moving, and many patients have these, and these are in clinical trials, to a so-called closed loop or artificial pancreas, in which continual glucose monitors are connected to the insulin pumps. They talk and they tell the insulin pump how much insulin to release. And so you've got essentially a pancreas that you're wearing on your belt. Truly remarkable. There are still issues with these, although the blood glucose control is excellent. They're not available to everyone. It's an expensive technology. The glucose sensors don't last too long, but it's a really amazing technology. And I think you're going to hear more and more of that as it improves in the coming years. Let's spend a moment talking about beta cell replacement by islet transplantation. I'm sure you've heard of it, and it's great because there's another great Canadian diabetes research part of this story, actually a couple of parts. So pancreatic islet transplantation is essentially when the islets that I showed you, that Langerhans discovered, are isolated from the pancreas of an organ donor. So this is someone who's died, who's donated their organs to research. The islets can be isolated, and they're simply infused into the portal vein, the vein that feeds the liver of someone with type 1 diabetes. And they lodge in the small blood vessels, the capillaries within the liver. And it's a good place for them to be, pretty good place, because That's one of the insulin-sensitive tissues, very important in glucose metabolism, that is the liver. And they do pretty well there. And these patients, I'll show you, regain a pretty good control of their blood glucose. And so the idea with beta cell replacement or islet transplantation is that by replacing the cells that have been destroyed or are dysfunctional in type 1 diabetes, you could eliminate insulin injections and decrease complications and decrease all of the worry that people with type 1 diabetes live with every day. So this is the impact of islet transplantation when it works well. So this is someone who has type 1 diabetes using insulin injections to control their blood sugar, and they have a continual glucose monitor, which I showed you in that earlier artificial pancreas slide. So they can measure their blood glucose moment to moment, and each different line here is a day of the week and their blood glucose tracing. And you're supposed to live in this gray area, the so-called normal or non-diabetic healthy range for blood glucose. And what you can see in this individual, despite best efforts to maintain their blood sugar under control, they have lots of hyperglycemic episodes and dangerous hypoglycemic episodes. So not great blood glucose control. Following islet transplantation, 9 months later, this is the blood glucose profiles in this same patient. And you can see almost all of the time spent in this normal healthy range. So remarkable blood glucose control is possible with islet transplantation. And really, when you think about it, it is remarkable because it's done by replacing just a few cells, just a lot of cells, probably about 1 billion cells, but the actual amount is not a lot. You can see the penny here. This is in the bottom of a tube. They've been centrifuged down. So it's a pretty small volume of cells that are transplanted in the liver. This is what the islets look like when they're isolated. You get other bits of pancreas and stuff in there, but the islets here are stained red with a dye that binds to insulin. So they're transplanted in the liver. They do very well there, and they can last for ages, as they have done in this person, Bob Teskey here with Dr. Peter Sr., who runs the Alberta Diabetes Institute. So you may have heard of the Edmonton protocol. That was a new protocol for islet transplantation that has really, I think, changed the lives of so many living with type 1 diabetes and really given hope for beta cell replacement therapy. And Bob is still off insulin, still doing well. He says it's nothing short of a personal miracle. The Edmonton protocol has given me my life back several times over. So another example of a great Canadian diabetes research story. Unfortunately, the long-term follow-up on patients who've received islet transplant shows that many, about 80% after 5 years or so, will return to requiring insulin to keep their blood sugar under control. They require less insulin, so they do better. Their blood glucose control is better, but the islet grafts start to fail. They also require immune suppression for the rest of their life so that those transplanted cells are not rejected. So it's still an experimental procedure. It's not perfect. We need improvements. And one of the other limitations is that we don't have enough cells to go around for transplantation. It's because we don't have enough organ donors. There are about 1 million people living with type 1 diabetes in North America. There are just not enough organ donors providing pancreas and from which we can get islets for transplantation. So there's been a lot of research, including some excellent research in the UBC system, trying to identify other potential cell sources for diabetes cell replacement therapy. I mentioned islet isolation here at the top, human organ donors. I won't talk about xenotransplantation or animals such as pigs as a potential source, but there's a lot of research going on in this area in other countries, some in Edmonton. And it's very interesting because pigs have islets that are very similar to humans. Pigs have very similar blood glucose control to us. So there is research in that area, and that is a potential cell source. Of course, it has lots of ethical implications, and not everyone is comfortable with it, but it is there nonetheless. I think a really exciting area is in stem cells, and I'm sure you've heard about this if you are reading about diabetes and type 1 diabetes. Embryonic stem cells, human embryonic stem cells, can be differentiated or changed through a series of steps into something that resembles an insulin-producing cell in an islet, and those can be directly transplanted into the patients. And there are clinical trials going on in this in Vancouver right now, one of the biggest clinical trial centers, work of Timothy Kiefer, who made some really important inroads into this whole process of making beta cells from stem cells. The cells are typically in humans are transplanted into a device first so that they can be retrieved and they can be sort of partly protected from the immune system, but they also get a little blood supply. And so we can monitor those graphs. Another interesting and exciting aspect, and we have some research going on in my lab, be happy to answer questions, is that you could potentially genetically engineer those cells in the dish, the stem cells, to make better beta cells. Could we make cells that survive better, that are camouflaged from the immune system, that secrete more insulin, that do better, that last longer? And there's some really exciting research going on in this area. This is a ways from clinical trial, but there's a lot going on in research labs, including my own right now. Spend a moment talking about immunotherapies, because I think there's been some real interest in this lately. You don't need to know all these or read all these. They have really difficult names that I have a hard time pronouncing. But essentially, immune therapies are in clinical trials in type 1 diabetes to prevent disease in those at risk. We can do a pretty good job of predicting who's going to go on to develop disease, as well as those who have just recently developed type 1 diabetes. I'm going to just show you data from one really exciting trial that just came out a couple of years ago now. It's for a drug called Tablozumab. And essentially, this diagram on the left shows the T cells, or the white blood cells, the immune cells that attack the beta cells and kill them in type 1 diabetes. And what Tablozumab is, it's an antibody that binds to that T cell, that white blood cell, and it prevents its activation. It actually gets activated by another cell called an antigen presenting cell, or APC. And so it no longer gets activated to kill the beta cells. And a remarkable finding, and hopefully you can read this, it's pretty small print because I pulled it from this New England Journal of Medicine paper, but it shows that in people at risk for developing type 1 diabetes, they had antibodies that suggested they would go on to develop disease. These individuals who received Tablozumab had a lower incidence of diabetes. And in fact, the incidence of diabetes was delayed by 2 years in those who received Tablozumab. Now, 2 years is not a cure, may not seem like a lot, but as you'll hear from our speaker today, who is a caregiver for someone with type 1 diabetes, a child, preventing type 1 diabetes or delaying it for 2 years would be huge in terms of impact on life. Of course, one of the downsides of all these immune therapies is they're not specific to the cells that are attacking the beta cells. So they cause more generalized immune suppression. They can make people sick, more susceptible to infections. So we need more research. There's some really interesting research going on in Calgary in the lab of Dr. Per Santa Maria with nanomedicines. The idea that we could do a silver bullet and just attenuate the action of those specific white blood cells that are targeting the beta cell. And I'll close with some of our own research because we're very interested in biomarkers in type 1 diabetes. We're starting a big clinical study at BC Children's Hospital with the idea that we can better predict disease and better track disease and the response to therapy in people with type 1 diabetes in clinical trials. So the idea here is we're going to get samples of blood, very small sample from people at risk or with type 1 diabetes. We can do all sorts of analyses. We can look at the genes, the DNA that will give them risk. We know that some genes increase your risk of type 1 diabetes. They may have immune markers. That's how we predict disease currently, is islet autoantibodies, other immune cell assays. And some of the work we're doing, I mentioned how important the beta cell is to diabetes, and we're very interested in what goes on with beta cells in type 1 diabetes, and particularly the beta cells that are left. Because I mentioned earlier on that in humans, they're not all killed, they're still there and they're dysfunctional. We're measuring proteins related to insulin and another one, IPP, which I'll show you in a moment, that are made in the beta cell. And there's much more going on in research in this area. There's bacteria in the gut, or the so-called microbiome. You may have heard of epigenetics. There's imaging. There's many more things, many more biomarkers being discovered and researched. And the idea that we might be able to get to some sort of composite biomarker. We'll know the DNA, we'll know someone's immune cells, their beta cell function. And the idea that not only could we definitively diagnose and better treat their diabetes, because as not all people have type 1 diabetes, of course, and sometimes they're misdiagnosed, but we're going to be able to better predict disease and also track them better in clinical trials. And really importantly, all of this work provides new insight into the causes of the disease as well. And I'll just end with a little bit of data from our own work. So we've been following another peptide, studying another peptide that's made by beta cells in diabetes called IPP. Don't need to know what it does, but it's a hormone that's secreted from beta cells along with insulin. And like insulin, it's also made as a larger hormone first called pro-IPP. So it's first made as a larger hormone that gets cut up into the active hormone that's the primary form that's secreted. And what we found in kids with type 1 diabetes at BC Children's Hospital is that pro form, the unprocessed form, is elevated in kids with type 1 diabetes. This is really interesting because this suggests that maybe there's some dysfunction or defect in how the hormones are actually made in the beta cells in type 1 diabetes. And it turns out the same is also true for pro-insulin. So we're now extending this to clinical trials and clinical studies, trying to see if pro-IPP as well as pro-insulin can predict type 1 diabetes better in those at risk, as well as do a better job at tracking disease and the response to therapy. And I'll stop there and just remind you what I said at the beginning as we celebrate the 100th anniversary of the discovery of insulin by Frederick Banting, that he said, almost 100 years ago, that insulin is not a cure for diabetes. And I think this is really important to remember. It is a great treatment. It keeps people with type 1 diabetes alive, living happy, healthy, relatively healthy lives, but they still face complications. It's still life-changing. They still have to check their insulin and blood sugar, check their blood sugar and injector or take insulin by pump every day. So we need more research, but as hopefully I've shown you, there's some really exciting stuff going on, a lot here in BC, at UBC, and across Canada. And it's a really exciting time, especially with all these new technologies at our disposal. And I just end with pictures of the collaborative research that goes on at the two campuses in Vancouver and in UBC Okanagan. We get together, at least before the pandemic we get together every year, twice a year, once in Vancouver and once in the lake here. I really miss these events, not just because it's so beautiful to come up to the Okanagan in the summer, of course, perhaps not today when the highways are washed out, but just to bring the community together to do our research in a collaborative way. There's such outstanding research and amazing trainees in diabetes research going across both campuses, and we're really excited about the future of diabetes research in BC. So I'll end there. I'm going to introduce a friend and colleague, a diabetes advocate, diabetes caregiver, a parent of someone with type 1 diabetes, a really outstanding communicator and consultant, someone that I'm working with in the BC Diabetes Research Network. She really gives it all for diabetes, and she's going to talk about her personal journey with type 1 diabetes in her family. I will unshare my screen and I'll introduce my friend Sheila Kern. Thank you.
Thanks, Bruce, and thanks everyone for having me here. As Bruce said, I'm here because 100 years ago, the discovery of insulin has saved the life of both my sister and my daughter. I am an uninvited settler on the lands now known as Vancouver and home of the Musqueam, Squamish, Tsleil-Waututh people. And I'm pleased to share a little bit about my story. I'm just getting my screen here. There we go. And I'll trust if you can't see that, you'll let me know. But I grew up small town Ontario in a very chaotic setting. I was one of 10 children, and one of my sisters, Angela, lived with type 1 diabetes. I have so many memories of growing up in that time and in that family, but so much of it actually is reminiscent to me about my sister's life and growing up in 1970s and early 80s with diabetes. I will say today she'd never let me tell you her age, but she's a healthy adult with 2 adult daughters and she's doing great. But back then, many of my memories are around just the care that she had and how they managed it. And one of it, she and my mom every morning would go into a corner of the kitchen and they'd chat. And I always kind of felt a little left out and wondered what they were talking about. And of course, now I knew they were trying to determine what her insulin needs would be for the day and get ready for her shot. And I also remember kind of them searching along her arms or her legs or abdomen and trying to find a spot without these big red welts. Angela used animal insulin at the time, and it left big reactions on her skin. And the other ones I remember, she had to test her blood sugar with through her urine, through sticks that she tested her urine. And of course, that would be hours after the fact. So, you know, when her sugar was low, out of that normal range, Bruce showed us, it was really low, and it was happened often. And, you know, I could remember her, you know, clenching her teeth and not letting anyone feed her juice, or, you know, punching and swearing, and all of those things we're not quite supposed to do or behave. And often at school, I could hear over the monitor, would Teresa Donnelly please come to, you know, this classroom? And she was my older sister. Our older sister was one of the only ones who could help Angela when she was really, really low and wouldn't be able to look after herself. So when my own daughter turned 5, and I got the call from our family doctor that the blood work showed Fiona had type 1 diabetes, I was shocked. I should have known. I mean, she was thirsty and, you know, peeing a lot and tired all the time. I absolutely should have known, but I was shocked and I was scared. And in that initial conversation, even before we got to children's, I remember her saying, do you remember how bad it was with your sister? And that's all I could think about, all of those bad things I just shared. But thankfully, technology's changed, science has changed, and Fiona's life is so much, these changes have impacted her life so greatly. So a few familiar pictures coming up, I think. I first met Dr. Verchere when we were a year into Fiona's diagnosis. I actually was part of the staff team at Children's Hospital Foundation. And then when she was diagnosed and they were looking for a family to speak at the opening of the Diabetes Research Institute, Fiona and I were chosen. So she was a little bit of a poster child to start with for the research center. And another one, you'll see a familiar photo there. But I remember meeting Dr. Verchere and his team of supporters from the diabetes lab. And that year I had counted and, you know, tried to estimate just how many finger pokes she'd had and how many needles she had to take. And, you know, as the numbers got higher and hundreds of needles and thousands of finger pokes, I start to cry a little bit. And just the first year is hard. The first year for any family adjusting to that life of type 1 is difficult. You're learning how to feed your child, how to keep your child safe again. And even, you know, if it was warranted or not, I found, like many other parents, that there was a really big fear for your child not making it through the night. You know, the thought of a dangerous low is something that we always lived with. And for years, Phil and I didn't sleep through the night. But it's amazing how quickly kids with diabetes do grow up. They have so many responsibilities and they have to take good care of themselves. This is, Fiona was a bit of an advocate, as I was, as she was first diagnosed, in a little journal she wrote for JDRF. I spent 3 nights in the hospital and another 3 days in a classroom so my mom and dad could learn how to take care of me. My sister Elsa had to stay at home with my Aunt Nora. The second day I was in the hospital, I was supposed to have my 5th birthday party. The doctors let me go home for my party, but I had to go back. Now diabetes is part of my family. We still have to talk about sugar tests, carbs, highs and lows. I still don't like diabetes. Well, honestly, Fee would still say that today. These were at 5 and 6, some of the things that she was most concerned about: not going on sleepovers without mom, or going on sleepovers, not having to eat her fish cracker, not having to count her fish crackers. She didn't want to be having to do sugar tests, and absolutely she wanted to be a regular kid again. I remember my mom telling me that when my sister Angela went away to university was one of the hardest times in her life because of the worry. She didn't know how Angela would be able to cope on her own. And I am so thankful that science and technology has progressed so much that those are just fears I don't have now. Fiona is 20. She's been away from home for 3 years. She has what Bruce showed, one of the closed loop insulin pumps. So she has an automatic setting that supports her baseline of insulin every day. And for her, it's a lifesaver. It's made it easier for her to live with diabetes and easier for her to control her health. Sorry, here we go. So when Fee was little, what did a cure mean to her? It meant that she could go swimming as long as she wanted without having to go low or worry about putting her pump back on, and that she could ski without checking her blood sugar all the time. I just saw Fiona in Toronto last week. She just turned 20 on the 13th, the day before World Diabetes Day. And her hopes are different now. It's, you know, she feels like she's doing a good job taking care of herself, but she's worried about the future and she's worried about complications. And she mentioned, you know, that I said, if you could talk about, you know, one of the things that was affecting you most about diabetes, she says loneliness. She grew up in a school where she was the only child living with diabetes. And then, of course, living or attending university during COVID. I don't think she's met many other people her age that she's been able to form a bond with who know what she's going through. But so that's my Fee, that's us. And we are always so hopeful for the changes in both science and technology to support a better life for us all. So thank you. I will stop sharing and I'll pass things back to Joan.
Great. Thank you so much, Dr. Verchere and Sheila Kern, for sharing that information about type 1 diabetes, the research discoveries, but also how those have changed the lives of real people in real families. So thank you very, very much. I'm now going to turn it over to Dr. Jonathan Little and JJ Belanger to talk about type 2 diabetes in a similar way. And so just to begin, Dr. Little is Associate Professor in the School of Health and Exercise Science here at the University of British Columbia's Okanagan campus. So I'll turn it over to you, John.
Thank you. Sorry, I'm just, my screen share was not working, but I think now it is. Excellent. Well, thanks, Joan, and thanks, Bruce and Sheila for that discussion. I'm going to switch gears, talk a little bit about type 2 diabetes and specifically remission of type 2 diabetes, which I think is provides some hope for this branch of the diabetes continuum, similar to the discoveries that insulin, of course, and then that Dr. Verchere discussed some of the new research related to regeneration or replacement of beta cells. I'm going to do a little backwards because I'm going to end with a video which will introduce our person with diabetes, our patient advocate, JJ. So I'm going to just acknowledge the funding and the Pharm TCR trial team. I'll present some results from a clinical trial that we conducted here in BC. So I want to acknowledge them first because I won't be able to do that at the end of my talk. So I have two main points that I want to make today. And the first is that remission of type 2 diabetes appears possible with very low calorie or low carbohydrate dietary approaches. I'll talk about that, and I'm sure we'll get to more discussion in the question period about exactly what some of these dietary approaches would look like. And then I think more importantly, to enable to help and support patients with type 2 diabetes, I'll talk about what I think are needed innovative care models that would have multidisciplinary teams that might include pharmacists, physicians, dietitians, certified diabetes educators, so that we can move from this goal of managing type 2 diabetes to try to give each patient the option of what I'll call remission, and we'll talk about the definition of that in a few slides. So Bruce did a nice job introducing diabetes. Because we're switching to type 2 diabetes, I just want to highlight some of the big picture numbers here related to World Diabetes Day in Canada. So 1 in 3 Canadians, or about 11 million Canadians, have diabetes or prediabetes. So prediabetes is a term that applies to type 2 diabetes. So this means you're at risk for developing type 2 diabetes, which, as Bruce mentioned, is a disease where the insulin isn't really working as well. So if the insulin's not working to lower your sugars start to creep up, and that would be prediabetes. Eventually, your beta cells can't handle, they can't work as hard, and that would be when your glucose would rise up to cross that threshold to become type 2 diabetes. So a lot of Canadians are living with prediabetes or type 2 diabetes. 1.5 million Canadians have type 2 diabetes and don't know it because they haven't been screened or tested for it. And certainly both or all types of diabetes are associated with many different complications. So this is certainly an important thing for us in Canada and BC to pay attention to. I know everyone's coming from different backgrounds, so just because we're going to talk about remission and definitions, I think it's important to understand how we diagnose diabetes. So all types of diabetes, for the most part, are diagnosed with these thresholds in blood sugar. And the most common one these days is hemoglobin A1C. So if your A1C is at or above 6.5%, then you would be diagnosed with diabetes. And then, of course, your physician or healthcare team is going to have to do further tests and figuring out to determine what type of diabetes that is, type 1 diabetes versus type 2 diabetes. But again, about 90% of diabetes cases are type 2. And that hemoglobin A1C is just a reflection of how much sugar is stuck to your red blood cells. So it gives an indication of how high your sugars have been over the life of a red blood cell, which is about 2 or 3 months. So it's a very good indicator of what your average blood sugar control has been. So these are what the diagnosis thresholds are, and this will be important when we talk about remission, because the remission is bringing glucose back down below these thresholds. I'm just going to put up a few quotes here, and these aren't attributed to anybody. These are things that are very common in the field of type 2 diabetes and common when discussing or talking with participants in our research studies. So you often see that type 2 diabetes is billed as a chronic and progressive disease, or something that's caused by lifestyle factors. You hear patients will say, my doctor said you have 3 months to fix diet or exercise, and then you'll have to go on medications. Lots of people with type 2 diabetes will say, I just want to avoid having to go on insulin. I don't want to have to take shots. And then you'll hear healthcare providers or people say, well, once you start insulin, you're going to be on it forever. And this creates a lot of, I think, despair, not a lot of hope, and it creates a lot of stigma, which is certainly not justified. Certainly our genes haven't changed in the last 50 years when type 2 diabetes has skyrocketed. I was on a walk with my daughter yesterday talking about giving this talk today, and she said, it's not fair to blame anybody for type 2 diabetes. Look at our society. It's cheaper to be able to buy junk food and to sit and stare at a screen. So you can't say that this is a blame someone or this is a personal choice. And my 12-year-old daughter understands that. So I don't think that the stigma associated with type 2 diabetes is warranted. And this is almost embarrassing to show this. This is from the World Health Organization yesterday on World Diabetes Day, and just the images and the stigma that they create, I think is appalling. So is there new hope amidst the stigma and despair? And I think there is, and that's the goal of my research program right now, as well as this talk, is to help discuss this new hope in type 2 diabetes remission. So we have to define this first. So what is type 2 diabetes remission? And Bruce and I didn't discuss this before, but he very nicely led into this. Certainly, we're not talking about cure for type 2 diabetes here, but these are some of the other terms that we'll talk about or will come up. Return to normal glycemia, drug-free diabetes reversal, but I think remission is the best term, and that's the one that's gained the most traction. So this is very emerging topic. So this is 2021 October. This is the American Diabetes Association coming together with the European Association for the Study of Diabetes, coming up with the first kind of ever consensus report on how we should define this. And they say that remission should be defined as return of A1C below 6.5%. So that, again, that's that threshold for at least 3 months without taking glucose lowering medications. Diabetes Canada is in the process of writing a clinical practice guidelines chapter that I have the fortune to be on that chapter about type 2 diabetes remission, and I'm sure that we will adopt similar definition here in Canada. So this is the definition. Where does it come from? Well, it comes from the bariatric or metabolic surgery literature. So bariatric surgery is now called metabolic surgery, if you want to be more accurate. This is when you're either rerouting the GI tract or making the stomach much smaller. And the research on this for treating type 2 diabetes or getting into remission is very impressive. I don't expect you to look at all these numbers. Essentially here, these are randomized control trials. There's a 19-fold greater chance, or you have a 19 times greater chance of getting into remission if you have metabolic surgery versus not having metabolic surgery. So certainly this is an effective way to get diabetes into remission for many people. But of course, metabolic surgery comes with a lot of risk and is not very accessible for most people. But this is where it came from. So that the concept of diabetes, type 2 diabetes remission, came from these findings after metabolic surgery, when patients would now have normal blood sugars and not be on any medications. And this can happen quite quickly after surgery. It hasn't really come into the nutrition or lifestyle or mainstream until very recently. And this is studies now coming out that are applying this concept to nutritional interventions. So there's ways that we now know can get type 2 diabetes into remission. One is following a very low calorie diet, or following a very low or a low carbohydrate diet, combining those approaches, so very low carbohydrate diet and a very low calorie diet. And then there's other ways where you might combine diets with intensive lifestyle interventions, largely around exercise. And I'll talk a little bit about each of these different strategies. So I think the first study that really has shown this in a randomized control trial design, which is the gold standard in medicine for testing a treatment, is called the DIRECT trial. And this was done in the UK. And they had patients that were newly diagnosed, so less than 6 years, who are not taking insulin yet. So you could think of these as people with type 2 diabetes that haven't progressed, or they haven't lost too much of their beta cells yet. And what they did is they stopped all the medications on day 1, and they had half the participants go on what they call total dietary replacement. This is a commercial weight loss product. It's soups and shakes, for the large part providing 850 calories a day. So this is all that the patients are getting for 12 weeks. And then after that period, they reintroduce food. So they meet with a dietitian and a nurse, and they slowly reintroduce food, and they have meetings to track this. And then they see at the end of 1 and 2 years how many patients are in remission. So having their glucose below that 6.5% A1C and not taking any medications. You can see here the results are fairly impressive. At 1 year, almost half the patients who got this treatment are in diabetes remission. And then when they try to say what predicts remission, or how do these individuals get to remission, it seems that weight loss is very key. So these are going from no weight loss, 5 to 10, all the way up to greater than 15 kilos or 35 pounds of weight loss. And you can see if you lose greater than 15 kilos, you have an 86% chance of getting your type 2 diabetes into remission. A similar study has, so that was done in the UK, largely in a white Caucasian population. Similar study done in Qatar, so individuals of Middle Eastern descent, and they followed very similar protocol, but they also included some exercise or physical activity in addition to that meal replacement strategy for 12 weeks, followed by food introduction. And you can see in this study, in a different population, different settings, 61% of the patients in the intervention group are in remission at the end of 1 year. So again, showing that this strategy can work in different populations, different settings. Another way that is gaining traction is this low carbohydrate or ketogenic diet approach. And this is largely based on the results of Virta Health, a commercial entity, a virtual specialist clinic based in the United States. They have done a large trial that's non-randomized, but the key here is it's a broad inclusion criteria. So it's not just patients who aren't taking insulin and not just patients who are newly diagnosed. However, the patients got to pick which group they wanted to get in. So they said, do you want to follow a very low carbohydrate diet or do you not? So that creates some bias in the medical research field, obviously. But the results are pretty impressive. The individuals that choose this approach at the end of 2 years have lowered their A1C by 1.2%, lost about 12 kilos, much of that from their abdominal region, which is obviously good weight to lose, so they're not just losing muscle mass in this. And about 18% of the patients in that group following that very low carb ketogenic diet achieve remission at the end of 2 years with that. Just want to point out, but lots of times this gets misconstrued, I think, as a keto diet reverses type 2 diabetes. And I don't think that's the case. The Virta is not just a ketogenic diet. The individuals have access through an app and a mobile portal to a health coach, to their physician, resources, as well as they're tracking their glucose and ketone levels and that. So it's a whole package here, not just a patient choosing to follow a ketogenic diet on their own, which is doing this. And I think that's important. But this type of data, I think, is supporting these low or very low carbohydrate diets as an option for patients. And Diabetes Canada finally came out in 2020 endorsing or at least allowing these types of low or keto diets to be used for individuals for improving their glycemic control in conjunction with the healthcare provider. So and now I'll just change gears, talk a little bit about the study that we just completed here in BC. So type 2 diabetes remission, as I mentioned, means withdrawing your glucose lowering medications. And this is very different from our clinical practice guidelines for type 2 diabetes management. There's nothing in the guidelines that tell physicians or doctors how to take away medications. Everything is based on adding medications in the guidelines. So how do we support persons living with type 2 diabetes to safely get their disease into remission when we don't really have any guidelines or ways to do this? So we need to manage this medication deprescribing so we can safely promote remission and prevent risks. So obviously, if you follow one of these diets and you take too much medication, you can have risk of hypoglycemia, much like Sheila was referring to in type 1 diabetes when you don't get your insulin doses right. And blood pressure also is another issue because many patients with type 2 diabetes are on blood pressure medications as well. So we tried to approach this with what we thought was an innovative way, positioning community pharmacists as the hub or the quarterback of an intervention to see if this combined low carbohydrate, low calorie approach could reduce the need for glucose lowering medications and improve health in people living with type 2 diabetes. We started the trial probably about 5 years ago, before type 2 diabetes remission was really a term. So we didn't have remission per se as an outcome, but you'll see that we did have people achieve remission. So I won't get into all the reasons here, but why are pharmacists, we get this question a lot, why are pharmacists involved in nutrition intervention? And we're not trying to say that pharmacists will replace dietitians, but pharmacists are much more accessible than other healthcare providers. They're in almost every community, urban and rural. So we think this is a scalable approach. People with type 2 diabetes would go see their pharmacists often to get their medications renewed, and then the pharmacist could offer a program like this as a scalable strategy. So we conducted a 12-week trial across 12 sites in BC. So these are all PharmaSave pharmacists in the community. We randomized at the individual level 188 participants with a broad inclusion criteria to either the pharmacist-led therapeutic carbohydrate restriction, which we call PharmTCR, or a guidelines treatment as usual. So they just got typical advice on diet and physical activity. The intervention was kind of a combination of the VERTA trial and the direct trial. So it's low carbohydrate to keep sugars low. And then it's also very, very low calorie, around 1,000 calories a day. And we do this with a commercial weight loss product supplemented with real foods. The key here is it's standardized so that the pharmacist doesn't need to guess at what the patient is eating. They can make medication adjustments knowing how many carbs and how many calories the person is eating. Treatment as usual just got standard advice, as I mentioned. So the medication deprescribing was designed by Sean McKelvey, a pharmacist and real pioneer in this area. I think he's online here today. So shout out to Sean here. The pharmacists create a medication deprescribing plan. I won't get into all the details here. It's if you're interested, it's published in the protocol paper. But essentially, they're following kind of an algorithm to decide which medications to reduce at which times. And I'll jump right to the results. Our primary outcome in the trial was getting participants off all medications. That was achieved in about 36% of the patients in the PharmTCR group are not taking any diabetes medications, none in the treatment as usual. If we apply that remission criteria, so about half of those who are off their medications have their glucose under 6.5% at the end of 3 months. So they're reducing medications while glucose is getting better, and many other health parameters getting better as well. Here's just a look at all the different types of medications, and you can see different classes. By and large, they're all coming off, and they're coming off very quickly, which points to the need to safely do this and have a procedure in place, because you need to remove many of these medications within the first couple of weeks. And we do some crude cost analysis. This would save our healthcare system around $1,500 a year if these were projected across a 1-year horizon. So we think the next steps are to try to make this more accessible and see the long-term effects. Obviously, it was only a short-term study, and we need to incorporate a multidisciplinary team. So the idea here is the pharmacist is the first link. They do that 12-week deprescribing phase, and then they would work with a dietitian. The patient would get an individualized diet that would fit their lifestyle, their needs, that would be supported virtually over 1 to 2 years, and then have an outcome of type 2 diabetes remission along a longer horizon. So I'm going to end with a video which will introduce our patient advocate, JJ. I get a little emotional every time I see this video, so I might turn my camera off here, and then I'll turn it over to JJ at the end of the video.
12 weeks ago, I was on a downward spiral that I couldn't see myself getting out of. And without this clinical trial and the people behind me, I wouldn't even fit in this chair today. I happened to go to the doctor and not get some great blood results, and had an honest chat with him and said, what if I did this? And he said, you know what, it's probably a great idea. So talked with my wife about it, talked to Laura about it, and Amber, who's my coach, and we embarked on this program of 12 weeks to rebuild me. The first 2 weeks was hell. Just my body adjusting to completely cutting out alcohol, not a drop, no sugar, very limited and programmed carbohydrates, and then protein and fresh vegetables. Getting that balancing act right was the hardest thing about the program. Once I got it right, I was dialed in, and things went really well. The biggest thing about it was the medication decrease that I went through. It was imperative to have not only the coaching team, but the pharmacist and the clinical trial team behind you, because it happened so fast. None of us expected it to happen this quickly, but without them, I wouldn't be sitting here today 55 pounds lighter than I was 12 weeks ago. It's not all about the weight loss either. I mean, that's definitely a side benefit of all this, but it's the way you feel. It's the way I have a new outlook on life. I you know, hate to use the word born again, but it's kind of the way I feel. And so, yeah, love my life. You know, it's fantastic. And I got a great opportunity to live again.
Morning, everyone. My name is JJ Belanger. As you probably saw in the video, I was shamelessly plugging the resort that I manage in Tofino, Crystal Cove Beach Resort. I was patient 1201 on Dr. Little's trial, and it was miraculous. I'm going to admit, it changed my life. When I started on the program, I was 387 pounds and just going in the wrong direction completely. My wife actually started on the Ideal Protein protocol about 3 months before I decided to jump on through this trial. And I, through working with her, started to see some weight loss. And so when this trial came along, I just said, there's no reason why I shouldn't do this. I mean, it's going to save my life, and it did. I got down to 275 pounds at my peak weight loss. Unfortunately, managing a very busy resort and the stress of COVID-19, I put some weight back on, but I was 2 years in remission, and there was no exercise involved in the program at all. It was really just controlling what you ate. And so once, as mentioned, after about 2 weeks of being on the program, I was dialed in. I really had everything going the right direction, and the medication drop-off was instantaneous. I was on 2,000 milligrams a day of metformin and 100 units a day of insulin, and literally cut the metformin in half at the end of week 2, dropped the insulin down to 50 units, and by the end of the first month, I was off all medication and stayed that way for 2 years. Unfortunately, as mentioned, with the stress of running a resort during COVID, I have gone back on metformin. However, I have started a very aggressive exercise plan, 30 minutes a day on a stand-up bike 5 times a week, as well as 10-pound weight, upper body weight training. So that has helped normalize my sugars again. And I'm focusing again on the same Ideal Protein protocol diet that I was on when I had the success. So working, unfortunately, our Pharmacist here discontinued that program, but we do have a Pharmacist across the island that I can access the food from, and they've been great with me. And so, yeah, I'm going to be back in remission here very shortly. Again, it's hard, especially when life throws you curveballs, but otherwise, without this trial, I don't think I'd be sitting here talking to you today. And so I have to thank Dr. Little and the support that he gave me, Laura, our pharmacist here at the Pharmacist, and my own personal doctor as well, just for guiding me through it. You know, when you're used to eating 3,000, 4,000 calories a day and not caring what you put into your body, it sure changes when you go down to 1,000 or 1,200 and are limiting that. But you know, after the first 2 weeks, it becomes real, and you realize the successes very quickly, and it's something that is sustainable. There is a maintenance plan you can get to, and that's what I'm going to be trying to do next. And once I get there, I plan on staying there. I'm never going to go back again to being on medication. That's just not, it's not in the future for me, and it's not something I want to do. So that's my plan. You saw the video, and I think it's probably the best thing that ever happened to me.
Great, thank you. What wonderful presentations. John, did you want to say anything before we move to questions and comments?
No, I just want to say again, like kudos to JJ, and thank you for joining us and sharing your story. And so impressive, and I think it's very fitting, providing hope on the horizon for diabetes. So thank you for sharing, JJ.
Yes, I totally agree. And thank you to you all. I think what crosses all of the presentations is that, 100 years ago, we had a great discovery, but that hasn't stopped our scientists and continuing research since then. And we're seeing the benefits of that research over the years and continue to do so. And the future looks very hopeful as we continue to do research in this area. And providing us a lovely glimpse from both JJ and Sheila into how these advances are affecting everyday lives of individuals and families. So thank you all for those great presentations. We do have time for questions and comments. So I'd encourage people to type any questions and comments they might have in the chat box. We'd be delighted to have a conversation with you and to try and answer those questions. Maybe to start it off, I might have a question for Dr. Verchere. I'm wondering, is there anything about remissions in type 1 diabetes? It's an interesting concept in type 2 diabetes. I wonder if there's parallel in type 1.
Yeah, it's an excellent question. I was really moved and intrigued too. I know Jonathan's work well, and to hear JJ's story and the idea that one of the reasons why it can work is that, for JJ and people, especially in the early course of type 2 diabetes, is that they still have lots of pancreas and lots of beta cells around, right? So if you can remove the stress through diet and lower that insulin resistance, the beta cells can do their job. In type 1 diabetes, we've thought of it as a disease of beta cell destruction for many years. But as I alluded to, we're now recognizing that you have, most people with type 1 diabetes have residual beta cells and they're dysfunctional. So we could, drive it into remission, potentially if those immunotherapies could block the immune attack, and then those remaining beta cells could either wake up or you could regenerate and make a few more. So I think where most of us, so this would be a therapeutic approach that would be different than cell replacement and transplantation and artificial pancreas. We would actually try to stop the autoimmune course of the disease in its tracks and bring those beta cells back. And I think those same immune therapies that are showing promise in prevention and delaying disease, I think are going to gradually be fine-tuned, become more specific for the beta cell attack. And I think there's a real promise. And I think we may end up going to a sort of a composite. I think the field thinks that we'll have a multi-therapeutic approach where we tackle both the immune system and beta cell regeneration. So the shorter answer is yes, I think we can drive it to remission, but and actually reverse it in people who have it. And that would be potentially free of devices. Sheila talked about what a cure is. I think even with islet transplants and artificial pancreases, you still have a device that has to be manipulated or removed or changed. So there's the potential cure there if we could really shut off the immune response and bring those beta cells back.
Great. Yeah, that sounds really interesting. I'll keep my fingers crossed on that, because that would be a really great advancement and support for individuals and families with type 1 diabetes. There is a question from Tina. Thanks for the wonderful presentation. The focus is on treatment. Is there any promotions that can be done in the community to lower type 1-2 diabetes? So maybe we'll start with you, John, and see if other people want to join in.
Sure. Yeah, I think Bruce could probably speak to the prevention. He did a little bit of prevention of type 1 diabetes, but for type 2 diabetes, certainly we know, I think if I'm interpreting the question correctly, promoting a healthy lifestyle in order to prevent the development of type 2 diabetes and at the community level. So certainly we know from large trials, with thousands of people in them, that healthy lifestyles, which is typically a diet that induces moderate weight loss, so about 5 to 7%, as well as encouraging exercise about 150 minutes per week or more, can prevent the development of type 2 diabetes in those people who are at high risk, so that pre-diabetes group I spoke of. And then certainly, you know, the issue there is, how do we get people to be able to do this and stick to it, and how do we do this at large scale? So I think there are examples of how this can be done. We have one right here, and started in the Okanagan, which is expanding across BC and Canada, that Dr. Jung, who happens to be my wife, runs as well. But that's called Small Steps for Big Changes, which is a diabetes prevention program in the community, embedded at YMCAs and expanding to other areas as well. So I think that there are promotions or things like that out there. The issue is again, how do we reach the people who need this the most? And Diabetes Canada has some emerging strategies in their 360-degree strategy to do more screening, so we can identify people at that pre-diabetes stage and then prevent the development of type 2 diabetes. And I think that on a large scale in Canada, we don't do a lot of screening for pre-diabetes or type 2 diabetes, and there aren't accessible programs for diabetes prevention, but I think there's some good work going on in that. So hopefully that answers the question somewhat.
Great, thank you. JJ, I'm wondering if you have anything to add about how we can promote prevention for type 2 diabetes before we focus on type 1. What would work, do you think, in the community to raise awareness?
Well, I think what worked well for the clinical trial was, again, engaging the pharmacists.
Mm-hmm.
They're the ones that have direct contact with the people in the community. They know who's a diabetic and who's not, because they're prescribing the medication. So I think that was the biggest help for me, was just being able to walk in every week. I had a journal. I logged my journal every day. I walked in, I was weighed, I was measured. We tracked the progress, and that was the success. And the reason that I went backwards and I'm now going back on is because the program stopped happening here in Tofino. There was just not enough participants in it. And so now that it's still going on in Parksville, I'm going to be heading there on the 10th of December to start the program there with them. I've been just focusing on exercise and diet right now. But yeah, having that weekly check-in and using your pharmacy to start this and to start the education process. And I mean, you know, I'd be the first person shouting from the rooftops to anybody who wants to do this, because it is successful. It is sustainable. And you can be off medication, like Dr. Little said. I mean, we could, if everybody with type 2 diabetes did this, how much would we save our medical, you know, community money? It would be incredible, and people would live longer. So it's fantastic.
That's great. Thanks for that. Dr. Verchere, do you want to talk about this question in relation to type 1 diabetes?
Yeah, I think it's a good question, because I think in type 2 diabetes, especially with, you know, this really exciting and interesting research going on from Jonathan and others, and the testimonials from people like JJ, it's really compelling, right? And so there is real evidence emerging that there are paths to remission, and that, you know, adoption of some of these protocols by the medical community, by pharmacists, could have a huge impact. I mean, when we think of, because I'm a wet lab researcher, how long it takes from a discovery to go to a drug, right? It can be 10, 20, 30 years. And this is something that can be impactful very soon. And I think but it's still slow to adopt. John will admit, you know, recognize that, you know, there's still lots of debate on Twitter about what's the best diet, you know, what's the best approach. And I think in the end of the day, it's evidence, right? And evidence-based medicine. And I think testimonials combined with the word of mouth, but also with people like Jonathan getting this into the clinical literature, the scientific literature, and people, you know, you can't deny data, right? If it says, and then I think it gets into clinical practice guidelines, which Jonathan talked about. So that adoption and promotion takes a while. In type 1 diabetes, it's a bit different because we don't really have lifestyle changes that we know are going to have a big impact on the disease, right? I think we're very careful to say that it's not a disease in which we really understand. We know that there's an environmental component, could be viral infections, it could be some nutrition aspect, but we just don't know enough to tell people how to live their lives differently. And so there isn't really something to promote. I will say though, in terms of, what the questioner was asking is where we can do a better job, I think, is access to therapies, access to technologies in particular, right? To pumps and glucose monitoring, because this is not in a country in which we have, good socialized medicine. There's still people pay out of pocket, right? People, and Sheila can speak to this, and not everyone gets access to these technologies, which can be really life-changing.
Mm-hmm. Sheila, do you want to add anything about access and helping people live the life that they want to live in the best way possible?
Thank you. I guess, in terms of type 2 diabetes, Jonathan spoke a lot about the stigma of diabetes and how negatively it can be perceived. And I think maybe changing the conversation around chronic health management. I mean, a lot of the strategies are the same, and type 2 is so complicated in terms of how you can get it and how it appears in different individuals. So I think there's a lot, the stigma that Jonathan originally spoke to. Access, while we're lucky to live in BC, continuous glucose monitors were just approved for coverage. Insulin pumps are covered for everyone across the province also, regardless of age. And Bruce is right. This isn't the same in every province across Canada. Mm-hmm. So these technologies that are making my daughter's life so much more livable or easier to maintain her own health, not everyone has access to.
Great, thanks for that. I see we have a lot of questions here, so I think I should focus on these. So first one is from Lori, and it's for you, Dr. Little. In the study, was sleep habits, sleep apnea, sleep deprivation taken into consideration, and or someone with sleep apnea excluded to participate? We often hear about sleep apnea linked to diabetes. So do you want to comment on that?
Yeah, individuals with sleep apnea weren't excluded, so there would have been individuals in the trial with sleep apnea. Now I'm thinking, so this is where clinical trials and get tricky. It would have been an exploratory outcome, so we weren't powered to discuss really make too much of a definitive statement on sleep apnea. But I think there was evidence that it did improve. We have sleep outcomes in another trial with a ketogenic diet in individuals with overweight and obesity, where we did actually see improvements in sleep quality index going up. I saw JJ put his hand up, so maybe he could speak to that more directly.
Yeah, I have sleep apnea, continue to have it, but my sleeping prior to the trial was horrible. I was on Zopicone and needed that to literally sleep more than 4 hours a night. Otherwise, I would wake up and my brain would start to work, and that would be it. So on the clinical trial, again, as we talk about demedication, that was one of the benefits. Was after a couple of months, I was able to start to wean off that. It did take a while, but I was successful and finally was getting 7 hours sleep without having to medicate. And so, yeah, I mean, it's another benefit. All my medications actually were literally gone. I was on blood pressure medication. I was on the diabetes medication as mentioned. And so, yeah, everything went away when I lost the weight and stayed on the program. So that's my focus again.
That's great. Thank you for that. I'm going to go to the next question from Jody. Is there research going on for late onset type 1 diabetes? Being diagnosed at 42 and now in my second year of treatment, I'm curious as to why this happened. Are there research groups we can volunteer to help with research? Bruce, Dr. Verchere.
Yeah, thank you for that question, Jody. So it's very interesting because we've thought for years as of type 1 diabetes as a disease of children and youth. And now we're seeing, and I'm not sure the incidence is increasing in adults. It's just that we're recognizing it as type 1 diabetes. It may have been misdiagnosed previously. There's other forms. LADA is one for late onset autoimmune diabetes, or might have been thought to be type 2 diabetes. There is more and more research going on in this area, but it is still a bit of a black hole. Unfortunately, there is some evidence that some things can trigger it in adulthood, perhaps a viral infection or something like that. Also, we think that people who get it later in life may have had underlying autoimmunity for some time, but it just wasn't beyond that needed for clinical presentation of diabetes. So it's quite possible that you had some attack going on your beta cells, some inflammation in the pancreas, if you will, for years before, but your beta cells were robust enough, your insulin sensitivity was good, and so you didn't get diabetes. And unlike type 2 diabetes, which sort of glucoses sort of go up very slowly over time, you tend to not have type 1 diabetes one day and then you have high blood sugars the next, right? It's very sudden. But probably, I'm going to guess that if we were able to go back in time and look at your blood samples before that, we could have probably seen evidence of autoantibodies, evidence of immune attack, and evidence of some dysfunction or loss of your beta cells and some, up and downs of your blood sugar. So it could have been something, and we just don't know what those triggers are. So I'm not going to ask you to dig back into the 10 years prior to try to find a stressful event or an infection that you had. We need lots more research on that. There are some rare instances where there can be drug-induced versions, some medications and things like that for people who are susceptible, but we definitely need more research. You're asking how you could help. If you reach out to me online directly, I can probably point you to some, but one of the best resources is TrialNet. If you Google that, and they're doing a lot of clinical trials in type 1 diabetes. Unfortunately, most of those are targeting younger adults and new onset forms. But if you reach out to me directly, I'll see what I can see what I find on that. We definitely need more. I will say that islet cell therapy, of course, can help potentially someone with at any age and any stage of type 1 diabetes. So you would potentially be eligible for that, even though you only were diagnosed with the disease in relatively late in life in terms of type 1 diabetes.
Great, thank you. There are some great comments here thanking people for their JJ for his testimonial. So that's, I agree, it's a great testimonial. And I'm wondering, I'm looking, oh yeah, so there is a question, there's some comments there that I'll let you read through. There is a question from, I think, Patricia, maybe, or Patrick. Is there any research into the long-term effects of these keto style diets? John, do you want to answer that?
Sure, yeah. So that Verta study that I showed has data published out to 2 years. That trial is going on been funded for an additional 3. They're coming up to the 5-year point in that cohort of patients, which they will, I'm assuming, plan on publish that. I haven't seen it yet. So that'll be the longest study that I'm aware of, a 5-year ketogenic diet study, which when you think about nutrition studies, that's a pretty impressive and long-term study. We don't have any data on any diet for following it for 15, 20, 30 years, especially in a randomized controlled trial type of fashion, right? So I don't think we have any evidence for any diets beyond about that 2-year mark usually. So this 5 years results will be very interesting. I guess one thing I want to say, the approach that we have, we know that diets, particularly restrictive ones like a ketogenic diet, you're restricting carbohydrates very, very low. People tend not to be able to stick to those perfectly for long periods of time. But the approach that I think, that JJ kind of discussed, his evolution now of it's an aggressive diet for 12 weeks or so, and then you transition to a maintenance phase. And then maybe 2 years later, you might have to go back to, what you call it, a rescue plan, or if you want to call it that, and do it again with that. And I think that might be the approach that we need to take, and that, we need to support participants and have these long-term, support and maintenance, because that's how I view it. So I don't think I view it as ketogenic diet for life necessarily. It might be a short-term period, and then you transition. I think obviously my view would be someone with type 2 diabetes, even after the disease is in remission, probably can't consume. There's probably a personal limit, that individualized limit of carbohydrates and calories that they would have to maintain their diabetes in remission. And that's what we don't know, how to determine that. And that's where I think, some of these technologies bringing over from the type 1 diabetes, continuous glucose monitors and that sort of thing, could help us to individualize or personalize that maintenance diet for somebody, so that it's not as restrictive as it was to get the disease in remission. But that's my opinion or thought on that.
Great, thank you. Wow, this has been a really great presentation, and I think we've answered all the questions and comments. So I'm going to bring this session to a close, but I know that it's a topic that is going to be of interest to people for a long time to come. And so I think over the next 100 years looks very, very exciting and hopeful, based on what we've heard today and the lived experiences and what benefit we've seen already from the research, and this is only going to get better. So I'd like to say I'd like to do this again in 100 years, but I'm not sure any of us will be here. But hopefully those who follow us will be able to repeat this session in 100 years. I look forward to the research over the next 50 years to some exciting changes. And so thank you to each one of our panel and to everyone who joined us today for this presentation to celebrate 100 years of the discovery of insulin. So thank you all again, and thank you everyone for joining us. Take care. Bye for now.
Thank you.
I think